Blood group immunology. Topic outlines in this lecture including blood group antigens, characteristic of antigens, factors influence the expression of blood group antigens, blood group antibodies, classification of blood group antibodies, clinically importance of blood group antibodies, and effects of immune response in transfusion sites. Blood group antigens are classified into two main groups, polysaccharides and proteins, based on its biochemical structure. First, blood group antigens which structure is polysaccharides. The antigenic determinant are specific sugar molecules that link to proteins or lipids. Example, antigen in ABO, H, I, P, and Lewis blood group system. Second, blood group antigens that are proteins and present on cell membrane in various patterns, including single-pass transmembrane proteins in both type 1, which N-terminal is outside, and type 2, which N-terminal is in cytoplasm, multiple-pass transmembrane proteins, and GPI-link proteins or GPI anchor. Examples of blood group antigens which are type 1 single-pass transmembrane including MNS, Lutein, and XG, and for type 2 single-pass is KEL blood group antigen. Many blood group antigens are multiple-pass transmembrane proteins such as RH, Diego, and KIT, and some blood group antigens link on GPI structure such as Cromer and Dombrock. This figure demonstrates a variety of blood group antigens expressed on red blood cells. Students can study by yourself for more details. Expression of blood group antigens in other tissues other than red blood cells. Some blood group antigens can be found in other tissues and secretions. For example, antigen A, B, and H can be found in saliva, but only in person who is secretor. This table indicates particular blood group antigens that can be found in other tissues and secretions. Expression of blood group antigens may change both in increase or decrease depending on some factors. First, psychosity and dosage, which resulting in dose of antigen expression and called dosage effect. Number of blood group antigen on red blood cells is double dose in person who has homozygous gene expression. This characteristic can be found in antigen of blood group Rh, Duffy, MNS, and KIT. Dosage effect has an impact on the strength of blood group antigen antibody reaction. Second, variation in adults and neonates. Some blood group antigens are expressed differently on cord or neonate red blood cells compared to adults of the same person. Patterns of expression can be absent, weaker, or stronger when compared to adult red blood cells. This table shows expression changes of some blood group antigens due to age of individual. Third, hormonal status and diseases. Expression of some blood group antigens is decreased during pregnancy, such as Lewis and A. And some antigens are increased when salicylic acid is cleavage in the presence of proteolytic enzymes, such as KIT, Lewis, I, P, and Rh. N-acetylase enzymes Secreting from a particular bacteria or cancer cells may temporarily change A antigen to B, such as acquire B. Fourth, expression changes when storage. Some blood group antigens deteriorate more rapidly during storage, with rate varies among different individuals, such as Duffy A, Duffy B, M, and P1 antigen. Medium with low pH or low ionic strength can affect the rate of some antigen deteriorate, such as antigen Duffy A and Duffy B. So, anti-Duffy A or anti-Duffy B may demonstrate difference in reactivity with red blood cells stored in different media. Age and nature of specimen must be concerned when perform red blood cell antigen typing. Antigen on red blood cells prepared from clotted blood sample tends to deteriorate more quickly than donor units collected in citrate. Interesting, samples in EDTA whole blood for up to 2 weeks are still suitable for antigen typing. Number of blood group antigen expression on red blood cell is different and may affect the strength of antigen-antibody reaction when detection. These tables show the amount of antigen expression in clinically significant blood group antigens such as ABO and I. KER and D antigen of Rh blood groups. Big C and little c, big E and little e of Rh blood group. Biomolecules that can induce the production of specific antibodies are called antigen or immunogen. They must have 3 basic characteristics of high molecular weight, which not less than 10 kilodalton, structural complexity or diversity, and foreignness. However, there are some factors that can enhance the antigenicity, such as charge, biological and chemical properties, structural conformation, solubility, and number of antigenic determinant or epitope. Each blood group antigen presents different pattern and ability to induce antibody production. These characteristics can be used to predict the frequency of antibody production and strength of antigen-antibody reaction which may occur when antigen-positive red blood cells are transfused to antigen-negative patients. From the table, the antigen of Rh blood group has the highest immunogenicity among those, following with big K antigen of K blood group system. In detail, it means that not all antigen-negative patients receiving antigen-positive red blood cells will certainly produce specific antibodies. For example, only 50% of Rh-negative patients receiving Rh-positive red blood cells will produce anti-D. Not only red blood cell antigens, antibodies to other antigens on leukocytes and platelets are considered in transfusion size because most of them are IgG and reported to involve in various transfusion reactions. These antigens are HLA antigens, platelet-specific antigens, and granulocyte antigens. Antibody to HLA antigens can cause transfusion-related acute lung injury, febrile non-hemolytic transfusion reaction, transfusion-associated graft versus host disease, and post-transfusion purpura. Antibody to platelet-specific antigens are reported to induce post-transfusion purpura, and antibody to granulocyte antigens may lead to febrile non-hemolytic transfusion reaction and transfusion-related acute lung injury. Two types of blood group antibodies are defined: non-red cell stimulating antibodies and immune type antibodies. Typical characteristics of non-red cell stimulating antibodies include mainly IgM type, induced by blood group antigen-like molecules, presents in blood circulation without history of transfusion or pregnancy, react well at room temperature or colder, bind red blood cells in normal saline and induce hemagglutination, fix complement and induce hemolysis. For example, antibodies to antigens of blood group ABO, I, Lewis, P, and MN antigen of MNS blood group system. Because non-red cell stimulating antibodies can directly induce agglutination, sometimes are called complete antibodies. Typical characteristics of immune type antibodies include mainly IgG type, induced by mainly protein blood group antigens, presents in blood circulation with history of transfusion, pregnancy, or transplantation, react well at body temperature, bind red blood cells in normal saline and induce sensitization, fix complement and can induce hemolysis. For example, antibodies to antigens of blood group Rh, KIT, KIL, and DAPI. IgG antibodies sensitize red blood cells, but cannot directly induce agglutination. Some enhancement technique may be required, such as antiglobulin test. It is sometimes called incomplete antibody. Class and subclass of antibody are different in ability to cross placenta, which can be used to predict the chance in inducing fetal complications. This table demonstrates some characteristics of major subclass of clinically significant antibodies to blood group antigens and platelets in terms of biological half-life and ability to cross placenta. Understanding of antibody subclass and its ability to cross placenta will help to predict the chance of developing fetal complications such as hemolytic disease of fetus and newborn, neonatal autoimmune thrombocytopenia, and platelet equivalent of hemolytic disease of the newborn. Ability of antibodies to bind complement has an impact to red blood cell lysis, resulting in severity of subsequently clinical events. In case that antigen-expressing red blood cells are transfused to patient having preformed antibody, the antibody will bind and opsonize the red blood cells. If antibody can fix complement, the complement cascade will proceed and induce membrane attack complex, resulting in intravascular hemolysis. In addition, some of red blood cells with incomplete complement activation move to RE system and are phagocytosed by phagocytic cells through C3b receptor, resulting in extravascular hemolysis. If antibody does not fix complement, opsonized red blood cells will move to RE system and are also phagocytosed by phagocytic cells, but through Fc receptor, resulting in extravascular hemolysis. Some blood group antigens induce production of clinically significant antibodies, which are defined as: first, reaction to red blood cells at body temperature. These antibodies are mainly IgG, but includes antibodies of ABO blood group system because of a wide range reaction. Second, degree of inducing hemolysis, such as ability to fix complement or to cross placenta. Third, Frequency of implicated antigen in the population. This can affect chances of individuals to antigen exposure and produce antibodies. This table presents the level of clinical significance of antibodies to blood group antigens, which vary from clinically significant to clinically mild, such as antibodies to antigen of blood group ABO, RH, or KIR are clinically significant, while anti-Lewis A or anti-MN of MNS blood group system are important only when react at body temperature. These tables summarize the characteristics of antibodies to blood group antigens by means of subtype and related severity when HTR or HDFN is induced. When antibody binds to red blood cells, multiple pathways are activated, leading to red blood cell destruction. Complement activation can lead to both intravascular and extravascular hemolysis. Activation of immune responses can lead to loss of efficacy in red blood cell transfusion. Understanding of antigens and antibodies helps in preparation of the appropriate red blood cells for patients at risk in order to prevent transfusion reaction that can cause fatality and morbidity.